Hey, what's going on? This is Timothy Gentry here with Cooper University Hospital EMS. I wanted to assemble a brief presentation on COPD and CHF. I found it important because we run into these situations in the pre-hospital setting where we have sick COPD and CHF patients and we just don't have as many diagnostic tools available. So at times it can feel like we're treating them empirically, which, can lead to self-doubt or uncertainty. Sometimes the patient's too sick to relay their medical history, or they don't know it, or there's a language barrier. So this can somewhat build confidence in your knowledge of COPD, CHF, and, hopefully help guide your treatment plans for these patients in the emergency setting. The objectives, they're pretty clear and cut. I want you to learn about the pathology, pathogenesis, and or pathophysiology of COPD and CHF. I want you to be able to compare and contrast the two and maybe have a better idea of what it is you're looking at, or, maybe it's an exacerbation of both, or, how to better guide your differential diagnosis in the emergency setting. And I want you to familiarize yourself with the protocols utilized for these clinical situations. So considerations, medications, pearls, clinical pearls, etc. This is going to vary by state, or if you're following national protocols, but I'm going to review what we do here specifically at Cooper University Hospital. And obviously we want to refresh anatomy concepts previously learned. All right, we're going to start off with COPD. We'll get right into the pathology. It's characterized by poorly reversible airflow obstruction and an abnormal inflammatory response in the lungs. Now, smokers who develop COPD have an enhanced or abnormal response to inhaling toxic agents, so that amplified response that they have is probably going to result in excessive mucus secretions, which, coincides with chronic bronchitis, tissue destruction, and or disruption of normal repair mechanisms, which will cause small airway inflammation or fibrosis. Right here you can see at the top of the lung, this is a lung removed from a COPD patient that got a lung transplant, but you can see that lobular lesion has coalesced to produce, severe lung destruction in that upper lobe. So I thought this was a pretty useful picture. It's a little bit grainy, but you get the idea. You can see the abnormality. So pathogenesis, inflammation is present in the lungs for smokers, and that first bullet point is, particularly the small airways. The defense mechanisms for limiting tissue destruction are impaired, and we kind of went over that in the pathology. You have those inflammatory and structural changes that persist even beyond the smoking cessation. So if you quit smoking, you're not necessarily in the clear, and you're going to put yourself at a higher risk for developing COPD. So the second and third bullet points, the imbalance between proteases and antiproteases, and the imbalance between oxidants and antioxidants in the lungs, I'll try to sum it up quickly. It's a little bit, I think this image does a really good job of tying it all together. This is definitely the more simple view, but that increased production of proteases and inactivation of antiproteases is going to result in an imbalance, right? So cigarette smoke and inflammation itself produce oxidative stress, which primes several inflammatory cells to release a combination of proteases, and it inactivates several antiproteases by oxidation. So the main proteases involved are those produced by neutrophils and macrophages, etc. And the main antiproteases involved in the pathogenesis of emphysema include, I don't think it's worth going into specifics, but it's like antitrypsin or secretory leukoprotease inhibitor. But, moving on to the next bit, the oxidative burden is increased in COPD. So sources of oxidants could include, obviously we've harped on it nonstop, that cigarette smoke, and reactive oxygen and nitrogen species released from inflammatory cells. So with that, you're going to create an imbalance in oxidants and antioxidants of oxidative stress. Many markers of oxidative stress are increased in stable COPD and are further increased in exacerbations. So oxidative stress can lead to inactivation of antiproteases or stimulation of mucus production, and it can also amplify inflammation by enhancing transcription factor activation, which is probably going a little too far into it. But just if you were curious about the second and third bullet points there, that kind of harps on it. Now for COPD pathophysiology. The pathological changes found in COPD result in physiologic abnormalities. I really don't want to read the slides to you because I think if you're watching this, you know how to read. But the bullet points themselves, I can go into a little more detail with each of these. I know we hit on them previously, but as far as the mucus hypersecretion and ciliary dysfunction go, the first two bullet points, that hypersecretion is going to result in a chronic productive cough. And you'll hear this, it's, characteristic of chronic bronchitis, but not necessarily associated with the airflow obstruction. And quite frankly, not all patients with COPD will have that symptomatic mucus hypersecretion. But, if you hear that productive cough, you can kind of clue yourself in. Ciliary dysfunction is that's going to be due to squamous metaplasia of epithelial cells. It's going to result in abnormal mucociliary escalator. And patients, because of that, patients are going to have difficulty in expectorating. Moving on, the airflow obstruction and hyperinflation, or you can just call it air trapping. The main site of airflow obstruction is going to occur in the small conducting airways, and other factors contributing to airflow obstruction will include the loss of lung elasticity due to the destruction of alveolar walls and destruction of alveolar support from the attachments. So the airway obstruction progressively traps air during expiration, which is going to result in hyperinflation at rest and dynamic hyperinflation during exercise. So hyperinflation, think about it, hyperinflation reduces the inspiratory capacity and therefore the functional residual capacity during exercise. So you're going to have these COPDers that, with the aforementioned features, they're going to, result in breathlessness and limited exercise capacity, which are all typical of COPD. As far as gas exchange abnormalities go, these are going to occur in advanced diseases and or in advanced disease and are characterized by arterial hypoxemia with or without hypercapnia. So the abnormal distribution of ventilation perfusion ratios due to the anatomical changes found in COPD is going to be the main mechanism for abnormal gas exchange. Moving on to pulmonary hypertension, you may hear people tossing around the term cor pulmonale. I believe that's the Latin phrase that they use, but this develops, the pulmonary hypertension develops late in COPD. So at the time of severe gas exchange abnormalities, that's when you can start thinking about pulmonary hypertension. The contributing factors are going to include pulmonary arterial constriction, that's because of the hypoxia, and endothelial dysfunction, remodeling of the pulmonary arteries, smooth muscle hypertrophy and hyperplasia, and destruction of the pulmonary capillary bed. Systemic effects of COPD, you're going to have inflammation, you're going to have skeletal muscle wasting, cachexia. All of that's going to contribute to limiting the exercise capacity of patients, and it's just going to worsen the prognosis irrespective of the degree of airflow obstruction. So these patients also have an increased risk of cardiovascular disease. And this right here is the asthma, COPD, and reactive airway disease protocol for Cooper University Hospital. If you want to further educate yourself on the medications listed on this protocol, or protocols moving forward, you can just look at the other videos that I assembled pertaining to pharmacology, pharmacokinetics, and whatnot. This is pretty straightforward. If you want to pause the video right now, you can get a good view of the protocol itself and really educate yourself on the map that loosely guides our treatment plan. But the big thing to take away is the pearls down at the bottom. The pearls are always the most valuable information, in my opinion. So take a look at the pearls and familiarize yourself with them, because those are really great takeaways. And you can even see, the fourth bullet point down, you get a sense of how sometimes there's crossover between COPD and CHF when you're trying to differentiate between the two. And And again, here is the protocol for asthma, COPD, and reactive airway disease continued. All good stuff. You can pause the video. You can look at this yourself. I don't need to read down every bullet point of this protocol to you. You can appreciate it for what it is. And now we're going to move on to CHF pathology. So when you think of CHF, you can think about which side of the heart's failing, or if there's complete heart failure. If you want to look at the outward appearance of the patient and try to pinpoint which side of their heart possibly has failure, you can use these to clue yourself in. So for left-sided, you're going to be looking for that pulmonary congestion and edema due to obstruction, reduction of renal perfusion, and reduced perfusion of central nervous system, which can cause that hypoxic encephalopathy. You have those really confused patients. As far as the reduction of renal perfusion goes, that second bullet point for left-sided heart failure, that confuses you. The causes are more than likely just salt and water retention and ischemic acute tubular necrosis or something like that. But moving on to the right-sided heart failure, it's going to be characterized by congestion and edema of portal and dependent peripheral sites. You're going to see that edema, pulling in the feet, ankle, sacrum, and effusions in the pleura and peritoneum. So you'll see ascites as well, possibly. Hepatomegaly, congestive splenomegaly, and renal congestion as well. Okay, CHF pathogenesis. So this picture is gives you a good view of your sick CHF patient. It gives you kind of the idea of what you're looking for as far as symptoms go. But for contractile impairment, more than likely it's referencing myocardial infarction, right? Because that heart attack is going to be the primary cause of cardiac failure in that, in that situation. Somebody has an MI, the myocardium is going to be damaged, and that's just going to result in an inability to pump efficiently and effectively. So ischemic heart disease can also contribute to heart failure, and that's going to be a similar mechanism as well. Moving on to restricted filling. If the heart is unable to fill properly during that cardiac cycle, then heart failure can ensue, obviously. This can happen if, for example, there's a stenosis of the tricuspid or bicuspid valves, or in the presence of, constrictive pericarditis where the heart cannot fill at ease. Volume loading, increased pressures, any obstruction or disease which increases the contractile pressures during that cardiac cycle can very clearly precipitate heart failure. Causes can include hypertension, aortic or pulmonary stenosis, PE, pulmonary embolism, and I think that pretty much covers a quick view of increased pressures. Volume loading, if the heart's overloaded with volumes of fluid, it can compensate efficiently within certain physiological limits in the short term. But eventually heart failure is going to develop, and if the problem is prolonged, it's more than likely going to develop. So issues related to volume loading will include regurgitation from any of the four main cardiac valves. Dysrhythmias is severe, think severe bradycardia and severe tachycardia. These can both lead to heart failure and filling where ejection times are delayed or augmented, and that's just going to exacerbate the situation. This right here is the CHF pathophysiology. This chart right here, if you follow this is a good, just pause the video and appreciate this chart. It really is a good chart that dumbs it down. I think it does a beautiful job of just kind of simplifying everything that I've talked about pertaining to CHF. You can follow that sympathetic compensatory mechanism part of the chart on the left, and you see the labels down at the bottom. You can follow the renin-angiotensin-aldosterone system compensatory mechanism, RAA. So obviously in patients with CHF, your cardiac output's going to be significantly reduced. Not always significantly, but it's just going to be reduced. And as a result, you're going to have those two tightly regulated compensatory mechanisms activated. And that was what I just talked about, the sympathetic compensatory mechanism and the RAA compensatory mechanism. So just pause it for a second, look at it, and you can kind of notice a part of the treatment for CHF in the emergency setting sometimes involves, ACE inhibitors, angiotensin converting enzyme inhibitors. And because of that, you can kind of see the negative feedback loop that you're shutting down by administering ACE inhibitors. And it kind of makes sense when you look at this chart. So pause it and enjoy. And this right here is the CHF protocol for Cooper University Hospital. Just take a moment. You can pause the video again. Just take a moment to appreciate this map that kind of loosely guides our treatment plan in the pre-hospital setting, and you can see why it is we do what we do. And when you ride on the ambulance, you have a better idea of what tools we have available for these hypertensive crises or acute CHF exacerbations. And again, as always, I think one of the more valuable things to take away from it is the very bottom, the pearls down there at the bottom. And, we put a big emphasis on nitroglycerin and it being the first line medication for CHF. So go ahead and read through, pause the video. Any questions, by all means, feel free to ask anybody, and they should be able to better elaborate on everything I talked about. All right, thanks so much. Take care.